Hello everyone, welcome to our Meet the Coroner with a specific look at leg ulcers because this is Legs Matter week. I'm just going to wait until we are at 6 o'clock, so about 30 seconds. Thank you all for joining on a evening. Hope you've all had a good day. And whether you're still at work or you finished work and come to join this session, thank you for your time. I'm just going to wait. Let's have a look. So we are at 6 o'clock. Hopefully you can see my slides. I'm also joined today by my colleague Charley, who's going to be manning the chat. So if you have any questions or anything you want to comment on, please pop it in the chat and we'll have little breaks in between the different sections and we can, I'll speak to Charley and see what's been put in the chat. So my name's Sam. I've been a tissue viability nurse for 18 years and I joined Coloplast a couple of years ago as the tissue viability nurse specialist, and I'm bringing you today's session. It's in sort of three parts. So the first part is going to be the importance of your documentation. So we'll start with that session first. Then we're just going to have a quick look at some of the products and services within Coloplast and some of our frameworks. And then we're going to go on to our Coroners Court. So it's a mock Coroners Court with videos. And this is a very interactive session. So lots of chat. There's some polls as well. So hopefully you can get involved with those. If the polls don't work for you, please, by all means, just pop your answers in the chat and we'll have little talks in between. So hopefully that covers everything we're doing today. So let's get on with the session. So like I said, oh, I've lost my little cursor. Where's that gone? Oh, here it is. This week is Legs Matter, and their theme for this year is it doesn't have to be this way. So poor lower limb care still continues to cause avoidable pain, harm and pressure across the NHS, but better care is possible. So that's sort of their strap line for this week. I don't know if any of you have managed to get onto any of their sessions, but I do advise you, if you can, go onto their website. They have lots of supporting documentation and sessions running this week, which will also support you out in clinical practice. So the importance of your documentation, and there's one saying that we're going to be hearing a lot during this section, and that is, if you didn't write it down, it didn't happen. And I know when I first started my first day of nurse training, this was something that was discussed and we spoke about. And it is really, really important that whatever you're doing with your patients, that you document it. And that's what this session is all going to look at and cover. So first of all, we're just going to look at your definition of leg ulcers. So obviously we've got the best practice statement here. So NICE defined a venous leg ulcer as a break in the skin below the knee, which is not healed within those 2 weeks. All patients with a venous leg ulcer should have a prompt, full holistic assessment, treatment for the underlying disease and appropriate wound and skin management. And for those patients diagnosed with a venous leg ulcer, the key component of their management must be strong compression. So when we talk about strong compression, we're talking about 40 millimeters of mercury, and that's to reduce that time to heal and risk further complications. But we know that out in practice, there is still multitudes of variations in care for patients with lower limb ulcers. We know that we've got our guidelines, we've got policies, we've got frameworks, we've got pathways, but still patients with lower limb are suffering out there, and we're not getting on top of these patients. So when we think about the costs, so this is the financial costs. So 1.94 billion, and this data was taken from 2017. So we know that the costs are going to be much, much higher. The average cost for managing a patient with a venous leg ulcer is £7,600 per year. Again, this is older data, so those costs are going to be higher now we're in 2026. And this can increase to 13,500 for unhealed venous leg ulcers. So just take a minute, think about your caseloads, think about those patients you're seeing and those patients that have had long-term, long-standing leg ulcers, and just think about those costs. and what you could do differently, how you can manage those patients better to get them healed and get them off those caseloads. There is a very high reoccurrence rates with venous leg ulcers. So only half of people with a venous leg ulcer heal within 12 months. And we know we've got all the guidelines. We've got all the compression systems. We have wraps, we have compression hosiery, we have bandages. But we are still finding that patients are living with lower limbs for much, much longer than they need to be. 70% of patients have reoccurrence if they're not fitted with compression hosiery. And I know that some of that is down to the patients. You know, they have an ulcer, they sort of walk into your clinic or to your place or clinical setting, and they basically just want you to take over and look after that leg. And as soon as it's healed, whatever advice you've given them, if you've fitted them for hosiery for sustaining that healed ulcer, they will leave the surgery and they will go back to previous management. But we need to make sure that we're empowering our patients. So we do talk a lot more about supportive self-management, and we know that where patients are involved in their care and they are doing some elements of supportive self-management, that reoccurrence can be reduced. So again, just thinking how we need to change, how we need to empower our patients to give them the confidence to look after these wounds themselves. So this was an NHS Right Care initiative. So again, back in 2017, it was called Betty's Story, and there's two pathways. So you can Google it and have a look at it. There's a nice animation that goes alongside this, but it's showing the difference between that suboptimal pathway, which is here, and the next slide, we're going to look at that optimal pathway. So what happens if we don't get it right? And this is the story of Betty. So Betty is a 70-year-old. She is identified as slightly overweight on her health check. At 74, she grazes her ankle and she puts a plaster on it. I've seen many patients through my tissue viability time where patients sort of self-manage. They just put a sticky plaster on and hope that that would heal. After 5 weeks, it still hasn't healed, and she sees the GP and she gets antibiotics. 2 weeks later, the medicines haven't worked. So she sees the practice nurse, who then gives her antibiotics and an antimicrobial dressing. She has this treatment for a further 6 weeks. Her visits are increased to 3 times a week. So you can imagine this patient, her exudate levels are increasing, the wound's not healing. I'm assuming she's just putting a dressing on and it's just deteriorating. So her visits are now increased to 3 times per week. So thinking of caseloads, what's that impact on the resources within your own clinical setting? What is that impact for Betty and her quality of life if she's having to go to a clinic 3 times a week? You know, that's going to have impact on her lifestyle. So after those extra 6 weeks of treatment, she's then given another antimicrobial, and this still doesn't work. So at this point, she's referred to vascular. She has an 8-week wait. So again, you would be assuming that she'd still be going to her practice nurse and getting that same treatment, and there's no progression in that wound. 8 weeks wait, then her notes are sent to the practice nurse and tries another treatment for a further 5 weeks. In the end, she can't tolerate her compression and she gets a cellulitis, and she's admitted to hospital for 5 days. So after various treatments and compression therapy, Betty finally heals after 2 years, and that is at a cost of £5,673. Well, I would argue that it actually cost a lot more, especially with a hospital admission. But not only that, it's what does that treatment cost for Betty's quality of life? Within the animation, if you've seen it before, or if, like I say, if you haven't seen it, please Google it and have a look at it. But it's the impact on her quality of life. She used to go out and see her friends. She used to do lots of walking. But because of this wound, she ended up being more housebound, not seeing her friends. So you think of that impact psychologically. She's therefore not doing her regular walking, so her muscles will be wasting down. There's obviously they're going to the clinic all the time or having district nurses in. And so that's 2 years of her life that's spent with a real focus on this wound and what it's doing to her. So that's that suboptimal pathway. Then we look at when we get it right. So this is what we want. We want these Bettys to get this right optimal pathway. So at 70-year-old Betty is given compression hosiery. So when she goes in for that practice nurse health check, they've obviously identified that she's got some edema, maybe some other signs of venous disease, maybe has some varicose veins, and they've identified that there's some elements of venous disease. So at that point, she's given compression hosiery, and then that becomes part of her normal day-to-day living. She knows that she puts on her hosiery, and that's managing that venous disease. At 74, she grazes her ankle and she visits the pharmacy. As per the lower leg pathway, she is seen by the practice nurse, and 2 days later has a full assessment and ankle brachial pressure index, or ABPI. After 5 weeks of treatment, the ulcer is healed. So if you think about that suboptimal Betty, where she had it for 2 years, with this Betty, our optimal Betty, after 5 weeks of treatment, the ulcer is healed. Betty continues to wear her compression hosiery with an annual lower limb assessment. Healed within 6 weeks, total cost £505. So this just really clearly illustrates where we want our patients to be, but unfortunately we still have that suboptimal Betty within the system, within the NHS. I speak with many clinicians, and I've seen in my 20 years of tissue viability, lots and lots of suboptimal Bettys. So if we can get it right, if you get to see that right clinician at the right time, get that right treatment, it's a much better outcome for the patient, for yourselves as clinicians, for the NHS financially. And we need to be working towards this. Like I say, we've got all the guidelines, the best practice statements, everything's out there, all that information's there, but we just need to ensure that we're implementing that out in clinical practice. Talking about the patient impact, so venous leg ulcers have been found to have a significant impact on a patient's quality of life. It's associated with that personal impact, social and psychological effects. We know that patients that have long-standing wounds suffer with depression. They often become socially isolated, especially if their wounds are quite edematous. They don't want to go out. They don't want to go and see their friends because they're embarrassed. There's that sort of shame and embarrassment around any odour. I had a patient that used to come to me at the clinic, and he used to get the bus to the clinic. He had lower limb ulcers, and they were quite odorous. And in the end, he became so embarrassed because of other people's reaction to him, moving away from him when he sat down on the bus, that he became really socially isolated. And that's sort of the real impact of lower limb ulcerations on patients. It has the potential for significant financial burden. So again, if you've got a patient of working age, and when I first came into tissue viability, most of the patients with leg ulcerations were a lot older, but as through the last decade or so, there's much more younger people coming with complex leg ulcers. And if they're of working age, it may be impacting them financially because of their work, because if they're having to leave work to go to clinic appointments, if they're having to get taxis, we know about the cost of living, the crisis that we're in, and the impact that can have for people if they're having to get taxis to go and attend clinics. They might find that, they're deciding whether they're going to go and get their leg dressing or are they going to feed themselves or put their heating on. Also, when you think about that financial burden, if you think about those patients that have really, really wet, exudating wounds, and if it's leaking and it's maybe going onto their clothes, going onto their bedding, and they're having to do all that washing, and again, that's going to have a financial impact on that patient. Pain is a significant factor, and is often underestimated, leading to poor management. We know that these wounds can be really, really painful for patients, and we need to make sure that we're doing the correct analgesia review to make sure we're getting the right pain medication to ensure that they're able to tolerate compression, being able to have the right treatment that's going to get them on that healing trajectory. An accurate assessment is crucial in ensuring correct treatment. We need to get that accurate diagnosis to get them in the most appropriate treatment plan. And I know it's hard. We have patients that we sort of say are non-concordant. And we know that some patients, you know, they do have a choice. If they choose not to have that treatment, absolutely, but make sure that we're explaining the outcomes to the patient so they're fully informed of what will happen if they don't take that gold standard best practice treatment. What does that mean to them? How much longer are they going to have that wound? And make sure you revisit that conversation regularly to make sure you document the conversation and what you've had. Not they've declined compression. Why have they declined it? Is there an actual reason? Be curious with your patients. Find out from them what their concerns are. Alleviate that where you can. We have lots of different compression systems. So we've got wraps, we've got bandages, we've got hosiery kits. And it may be that you need to adjust what system they have to make it more manageable for them. And also think about the language that you use with patients. If you say to somebody, oh, we're going to put you in this tight bandage, you know, straight away that patient's going to be thinking this is going to be feeling tight. But if you say we're going to put you in a really supportive bandage that's going to give you the best outcome for this wound, it will change their mindset. It will change that language that you're using. So the National Wound Care Strategy recommendations for the lower limb ulcers. So for leg ulcers that have no signs of the red flags, which are down below, first line is mild graduated compression, so 20 millimeters of mercury if no flags are present. So if there's any signs of acute infection of the leg or foot, that is a red flag. So you would not be putting on any compression at that point. If there's symptoms of sepsis, acute or chronic limb-threatening ischemia, suspected DVT, or suspected skin cancer. So if any of those red flags are present, you would not put any compression on. But if none of those red flags are present, National Wound Care Strategy recommendations are to put on 20 millimeters of graduated mild compression. A person with a leg wound presenting should be assessed, including a vascular assessment of arterial supply within 14 days. So if you think about your caseloads currently, is everybody that has a wound on their lower limb had a full lower limb assessment within 14 days? This is what we should be aiming for. This is what we need to be getting into a state of doing with our patients to ensure we're giving them that correct treatment in a timely manner. So leg ulcers with adequate arterial supply should go straight into that strong compression. So you can do your reduced compression until you've finished your complete lower limb assessment, and then you get them into that strong compression if it's a venous leg ulcer of 40 millimeters of mercury. Monitor healing as well, at least 4 weekly, because we need to make sure that the treatment that we're giving is actually achieving what we expect it to. If it's deteriorating or no significant progress is being made, we need to escalate. So you may need to escalate to your tissue viability service, to your vascular service. But if the wound is not improving and you've got the right diagnosis and you've got the right treatment, have to be thinking, why is this not progressing? And get support from your specialists in your area. You may need to refer for venous surgical or endovenous interventions. So again, follow your local policies and procedures, but it may be that they need surgical intervention to support that healing. So we've talked about what a leg ulcer is, the guidelines. So now we're just going to move a bit more into our session today, which is around the importance of our documentation. So we've gone into sort of that litigation. So NHS Resolutions is a body that pays out for harm that's caused to patients if they haven't received the care that they should have. So some of the common clinical failings in leg ulcers was failure to carry out a proper vascular or Doppler assessments before applying compression, delays in cleaning necrotic tissue, so doing that debridement, doing it in a timely manner. If there's dead, devitalized tissue sitting within that leg ulcer, we need to be removing it as effectively and as quickly as possible to minimize that risk of infection. Ineffective offloading, when you're specifically looking at your diabetic patients, so for diabetic ulcers, may need to make sure we're doing that offloading. And then what we're going to talk a bit more about is that poor record keeping and a failure to refer patients onto those other specialist teams. And these are just some of those common failings that have been seen out in clinical practice. NHS Resolutions, so like I say, they're a body that pay out for claims sort of against the NHS where care isn't what it should have been. And just last year, over £2.2 billion was paid out in litigation. So if you think about that sort of money, and that's just in 1 year, and that's not just to do with wound care, that's across the whole of the nursing and midwifery, but that's £2 billion that has just been spent where patients have been failed. So when you have a patient safety incident, you have to report it onto the framework. So this is the PSERF. So the patient safety incident is reported on the clinical reporting system, and it's about identifying and giving that compassionate engagement and involvement of those affected by that patient safety incident. It's about learning. It's not about apportioning blame. It's about what's happened here. What can we learn from it? How can we change processes to make sure this doesn't happen again? So when you're thinking about your patient safety incident, so if we're specifically looking at leg ulcers, obviously in years gone by, it was very, very pressure ulcer related, wasn't it? But that was where your wound care incidents were mostly reported. But not giving the right treatment for leg ulcers is still harm to a patient. If you're not providing that right treatment, that is harm for the patient. So we need to make sure that we are highlighting where we haven't managed those patients appropriately, because that's how we will learn. So like I say, you do your patient safety incident reporting. The incident may need to be verified by a clinician deemed appropriately trained. So that may be your tissue viability service. It may be just the local team lead. But just to make sure that what's been reported is accurate. And then it's that compassionate engagement and involvement of those affected by the patient safety incident. So that's your patient, staff that were maybe looking after the patient. It may also be the patient's family. And it's about being open and communicating those patient safety incidents, explaining what's happened, what that means in terms of their care and ongoing treatment, and being open and honest. It's about being considered and proportionate in your response to the patient safety incidents. And then it's about putting in processes in place to mitigate that happening again. And that needs to be shared internally, also nationally. Things are shared to make sure that it's all that learning is absorbed and reflected on. So there are possible consequences when things do go wrong. You may have disciplinary or capability hearings that may be done locally, or you may be referred on to the NMC and have to do a fitness to practice. It can end up in a coroner's inquest, which obviously we're going to be looking at in more detail today. When I first came into tissue viability, and used to, go into a coroner's court was something that very, very infrequently happened. But more and more recently, more and more people are ending up in coroner's court and having to either do a statement or having to go onto the stand to discuss the treatment that was given. You could also end up at Magistrates Crown Court, Court of Protection, So, you know, we need to make sure that we're protecting ourselves as much as possible and make sure that our documentation is able to support the care that we have given to patients. We are accountable. We sit on the NMC register. We're professionals. We are accountable for the actions and the omissions in our practice. So we need to make sure that we document what we've done, why we've done it. If we omit something within our practice, we just make sure we've got that clinical reasoning, justification written down to support the judgments that we make. Nurses make judgments in a wide variety of circumstances. You use your professional knowledge to make those calls. You use decision based on evidence for best practice and the person's best interest. So as long as you're able to document why you've done something and your clinical reasonings behind that, you are supporting yourself. Nurses and midwives need to be able to justify the decisions that you make. So that is where your documentations should support your decisions. Professional duty of candour. So I remember when this first came out and everyone was quite fearful about sort of saying that we've made a mistake or we've done something wrong or harm's happened to you. Everyone was quite concerned about it. But of all the complaints I've had to manage whilst working in the NHS, the main reason was always down to communication. I think if you communicate openly and honestly with patients, with their family, explain when things go wrong, apologise for it, move things forward, say how things are going to change, that you're going to investigate it and you're going to be keeping them up to date, let them know what's happened. It's vital that health and care professionals understand their responsibility to be open and honest with people. And that is really, really important. And I think since duty of candour came out, after all the fear that was initially there, in actual fact, complaints go down. Complaints went down in my trust because we were being much more open and honest with our patients. So what is the role of the coroner? So the coroner is jurisdiction is limited to determining who the deceased was and how, when and where they came by their death. So that's what the coroner is there for, to establish how, when and where they came by their death. When the death is suspected to have been either sudden with unknown cause, violent or unnatural, the coroner decides whether to hold a post-mortem examination and, if necessary, an inquest. So that is the role of the coroner. So they listen to all the evidence and then they make their verdict. So inquest, so there may be a pre-inquest hearing. So if a full inquest can't be held within days of the death, the coroner will open the inquest at a short hearing called a pre-inquest review. The coroner will decide how long the inquest is likely to last and whether a jury will be needed or whether any other hearings are needed. So that's your pre-inquest hearing. And then you have your coroner's inquest. So that is a legal inquiry into the death, and it's held when the cause is unknown, violent or unnatural. The coroner usually holds these in public. Sometimes they may not be held in public. That may be if it's either a high profile case, or sometimes if they involve children, it won't be held in public. But most coroner courts are held in public. And you can Google to see if there's where your local court is, and you are able to go and sit in the public area and watch coroner's courts inquests. If you are called to a coroner's inquest, you have to appear. It's not something you can decide, oh, do I want to go, do I not? It's something that you have to go to. Your duty is to the court and the coroner, and they will expect you to answer their questions as accurately as possible under oath. So you do have to take an oath. It is a scary place, I'm not going to lie. You will be supported. So this is something else to really remember, that if you work within the NHS, they will have legal teams and they will support you with this process. But you will review all notes, all documentation, you will put statements together, and you will be supported. And it's not about apportioning blame. It's about finding out what's happened. And your records are valuable to you to be able to support you in answering those coroner's questions. I don't know if anyone else is like me, but I know that once I've slept tonight, I've, struggled to remember what I've done today. I could still be called to coroner's courts for patients that I've seen a year ago, 2 years ago. So the only thing that I will have to support what I did for that patient will be my documentation. So again, just reiterating the importance of your documentation. You should only state facts when giving evidence. So don't think, oh, I'm sure maybe I did that and I did that. If it's not written down, it didn't happen. So you can only use the facts of what you've got, records present to be able to support what you've done. If you don't know the answer, it's all right to say you don't know. Don't sort of try and think of what you might have done, or I could have done this or I could have done that. If you don't know, just say I don't know. So once all the evidence has been heard, the coroner will come out with a fact, verdict or conclusion. Usually they refer to them as conclusions. So these are the conclusions that may be appropriate for that coroner's inquest. So natural causes, quite self-explanatory, that normal development of a natural illness is not significantly contributed to by human intervention. Then you've got accidental death or misadventure. So I often think, especially a couple of weeks ago when we had that heat wave, an example of an accidental death or misadventure could be one of those poor children that went into lakes and unfortunately they ended up passing away. So that was a misadventure. They went into a lake, they got into trouble, and unfortunately they passed away. So that would sort of sit in your accidental death or misadventure. Unlawful killing, again, quite self-explanatory. So murder, manslaughter, and serious driving offence. Suicide, so where the deceased voluntarily acted to end their life in a conscious way. Neglect, so that is a gross failure to provide the deceased with basic needs. So if you think of your basic needs, food, water, they're your basic needs, aren't they? And if you have gross failure to provide those, that's where your neglect would sit. And then you've got narrative. So this is where the coroner sets out the circumstances of the death in a detailed way, based on the evidence heard. So they will explain all the actions and things that have happened within that patient's evidence, and they will just detail it in that way. There's also Regulation 28. So after an inquest, if the coroner believes that there is still a risk to patients, they can issue a Regulation 28. So if they've heard the evidence and they feel that further avoidable deaths could happen, this is their preventative action they need to put in, and it needs to happen within 56 days. So the report is sent to the personal authority who have the power to make those changes, and they have 56 days to show how they have made changes according to the coroner's recommendations. So what I did earlier was I went on and I Googled, and I actually found a Regulation 28 that was submitted around a lady with a leg ulcer. So I'm just going to give you a bit of a review of what this was, and it may just put a bit more into context what this Regulation 28 is. So this is around a lady who was aged 58. The investigation concluded that the medical cause of death was septicemia, soft tissue infection, and pneumonia. So the circumstances of the death, this lady sustained a small laceration to her left lower leg. She injured it on a van. She sought help from her GP practice, and appointments with the practice nursing team commenced. Over the course of the following 11 months, she attended multiple appointments where the appropriate lower limb framework was not followed, and opportunities to escalate her wound and deterioration were missed. She was later admitted to hospital and was treated for an acute infection. She was then discharged to the care of the district nursing team. Again, the lower limb framework was not used consistently, and opportunities increasing her deterioration were not recognised and escalated. She was then admitted again to hospital, where at this point she was extremely unwell. The hospital commenced active treatment. She didn't respond, and unfortunately she passed away. So the coroner put their concerns down. So their matters of concern are, during the course of the inquest, I heard evidence that the GP practice did not follow the lower limb framework. They failed to refer to the tissue viability team, failed to escalate concerns around the deteriorating wound or consider appropriate measures to support the deceased, to either manage her wound at home or to support her attending appointments. During the inquest, I received evidence that the practice had not carried out any internal investigation. So that's why that coroner was concerned. So they issued this regulation 28. So the GP practice had 56 days to respond, to show what they've put into place. And again, it's all about that learning. What are they going to do differently to mitigate this ever happening to another patient? And I have got their response for this. So what they did was they appointed a wound care lead for the practice. They ensured the wound care template is used in full and at every consultation. And then they have regular 4-weekly review to confirm that all the information is recorded. They review all patients in the practice. And they ensure that they have regular reviews monthly, and then once every 3 months they have a full assessment of anyone with a wound. They ensure Datex reports are filed and are investigated. They've done wound management training. They've followed all the local guidelines, and the list goes on all the things that they put in, but that's what this regulation 28 is about. It's about where it shows the processes and the changes to practice that have happened to ensure this doesn't happen again to another person. So that is your regulation 28. I hope that helps explain it a bit more. And like I say, I just went on and Googled regulation 28 leg ulcer, and lots comes up. Sometimes you can end up going down a rabbit hole because you start reading lots and lots of things, but I think it really, again, just helps you to understand what this is. Obviously, as a trust, you don't want to have a regulation 28. It doesn't look good, and you don't want to have that as on sort of like your record, as if I can say that. So often what you'll find, and through the videos that we're going to watch when we do the coroner's court, is that you put changes in to mitigate it so that then you don't get this regulation 28. So record keeping, clinical governance and documentation. So record keeping is an integral part of nursing, midwifery and allied healthcare professionals' practice. It is essential. It is absolutely part of your day-to-day role. It's the provision of safe and effective care. It's not an optional extra, and documentation should be done as close to the event as possible. It's really hard. I remember when I first started my training, and you would do sort of like your shift, and then at the end of the shift, for the last half hour, the nurses would sit and get all their folders, and they'd sit there and write all the documentation in that last half an hour before they're just about to finish their shift. That's not the most effective way to do your documentation. You should do it as close to the time that you have carried out that treatment. There are lots of new AI things coming in. So I've spoken to a few clinicians where there are new apps or things that can record your consultation, and then they summarize it, and then obviously you would proofread it to make sure everything's accurate. But again, we have to think how we can work smarter. And I think more and more of these types of technology and digital support will be coming out. But until that day, or if you're already in a trust that's already looking at this sort of technology, we still need to make sure our documentation is fit for purpose. And it's not about writing War and Peace. It's about getting the real key elements written down succinctly. I often say to people, if you know, when you've seen other people's documentation, you think you can sort of say, oh, well, that looks really good. They've really captured everything in their documentation. Share that. Look at each other's documentation. Do you think that this covers everything that we've covered in this treatment? Ask your colleagues for support. Use frameworks. Obviously, with wound care, we have the TIMES framework. That's a very commonly used acronym that makes sure that we cover each aspect of that wound when we're documenting it. Records include anything that make reference to the care of the patient, and any records can be used as evidence or called as evidence as part of a serious incident investigation, trust disciplinary hearing, or investigation panels or coroner's inquest. And this is just a few examples of all the forms of records that will be called for. So you've obviously got your paper records. I think we're seeing less and less paper records now. We're a lot more digital out in clinical practice. But we know when I first came into nursing and I started off as a community nurse, you know, we had a proper old-fashioned camera, and you'd take it out and you'd have to wave it around to get the picture, and then you'd pop that into the notes in a plastic file. You know, we have the ability now to do lots of digital photography. Make sure we're utilizing technology. Use your photographs to show what your wounds look like. So going back to all forms of records that may be called upon. So you've got your paper, your electronic emails, handwritten clinical notes, letters to and from healthcare professionals, all the care plans, your wound and risk assessment forms, photographs. Like I said, use your photographs. Most people have access in their clinical setting to digital photography. Utilize that. It shows the progression of those wounds. Lab reports, x-rays, telephone conversations, really important that we document our telephone conversations. As a community nurse, I always had a pad of paper and a pen by the side of my car, because often, you know, you get those conversations, you have to pull over and just make notes to remind myself what was said, what time it was, who I spoke to, and the key parts of that conversation to make sure that it's all documented, and also medications. And again, I'm going to keep saying this, if it is not recorded, it didn't happen. And I still remember on my first day of nurse training, this was something that we spoke about. Careful and accurate records may assist you if you have to defend claims of negligence. And if you go on to Google again, and if you put in pressure ulcers, the first thing that comes up are a big list of lawyers that will support you in making a claim. We know that we're there's much more litigation in healthcare, and we need to make sure we're protecting ourselves. And it's your documentation that will do that. It will confirm what you've done, why you've done it, your rationale for doing it, and you need to make sure that you're writing everything down. Some of the common problems that are seen when you're looking into cases where patients have ended up having harm is that absence of clarity. Failure to record action taken when problems identified. So if you've seen a patient that has signs of local infection and you've just written, you know, erythema present, odorous, exudate increasing, purulent exudate, but you've not actually done something within that treatment plan, that's where you have missed and you failed to actually treat the problem. You may have recorded it, what the problem is, but you then need to do something with that information. Failure to escalate, failure to involve those specialists around you. If that wound's not progressing as you would expect, you need to escalate. You need to get your vascular team involved, refer to podiatry, refer to tissue viability services. Sometimes there might be missing information, missing and inaccurate wound measurements. Again, there's a lot more apps out in that are available. They're obviously very costly, but some trusts have looked into it and they're now using Healthy IO is one of the apps, so you're able to take a picture and it accurately measures the wounds. But if you're still using a paper ruler, make sure that you're using that accurately, not just sort of doing an estimate, just like, oh, it looks like it's about 2 by 3 centimeters. But if you are, that's all you've got available to you, make sure you document approximately what the measurements are. And also there's inaccurate information. Common examples that have been found in patient records. So this one does make me chuckle a bit. Leaking plus, leaking plus plus, or leaking plus plus plus. So what does that actually mean? My plus plus may be your plus plus plus. So how can we document that better? Is there leaking on the outer bandages when you've come to go and redress that leg? Is the exudate contained within the dressing, or is it not? If it's not contained within that dressing, what are you going to do to mitigate that happening again? Is it a case of actually it needs a more absorbent dressing, or does it need more regular dressing? Do you need to increase visits? Need to really think about how we're documenting. Dressed as plan. What plan? There may be multiple plans within the notes. So ensuring that you've really explained which plan it is that you have dressed that ulcer, and is there only one wound? I've been to many patients that have multiple wounds. So identifying which wound it is that's been dressed by which plan. Ulcer deteriorated. So why is the ulcer deteriorating? What are the indicators that are telling you that that ulcer's deteriorated, and what is going to happen following that? Ulcers deteriorated, are you going to escalate onto another service? Is there localized infection? Is that why the ulcer's deteriorating? What are you going to do to support and treat that? Care given as plan, again, may have multiple care plans, so need to be more specific. Compression applied. What compression's been applied? Is it 20 millimeters of mercury? Is it 40 millimeters of mercury? Is it a bandage system, a hosiery kit? Need to give that more information. Compression declined. Why is the compression been declined? Is there a clinical reason? Is there that the patient's declined it? Have they got capacity to be able to make that decision? All of these things need to be investigated and thought of. And we can support your documentation by just adding 3 little words. So these are just some examples of where just adding that additional information just gives you much more. So wound to leg, but actually which leg? Whereabouts, but if you put wound to leg, left medial malleolus, you know exactly where that wound is. Again, when you're thinking about patients with multiple wounds, it's really important that we get the right area. Antimicrobial applied. Why has an antimicrobial been applied? To manage that bacterial burden. So hopefully this is quite self-explanatory, but it's really important that we add in those extra details. So that is the first part of our session today. So that was just looking at the documentation and why documentation is so important. I'm just going to quickly ask Charlie if there's anything in the chat or anything to go over before I move on to our Making Life Easier section.
Hi, Sam. There's just a few people that have either attended or written statements for Coroners Court, so just sharing some things in the chat for that. Quite a few people asking how that they can experience going to a Coroners Court. So I've just advised you need to have a look. If you Google where your local Coroners Court is, they generally have a list of them on the website and you can go along. You don't need to ask for permission. They are held in public. The only ones that aren't are children. And anything that could be related to public safety, they're generally in a closed Coroners Court. But they are, of course, they are sad, but you can learn a lot from them, and listening to how other people have used their documentation to help them answer their questions is really quite beneficial to help you with your documentation going forward. But brilliant session so far. Thanks.
All right. Thanks, Charlie. And great to see that you're using the chat. Like I say, it just makes it a lot more interactive, and you know, I think it that there is just more and more people when I'm going out to clinicians that have either done the statements or have attended coroner's court. So thank you for sharing that for those that have. So now we're moving on to a bit of our Coloplast framework. So this is about making life easier. So at Coloplast, we use the 3-step approach, and it's a simplified framework to progress those wounds into a healing trajectory. So your step 1 is your assessment, and we've sort of covered that a bit at the earlier part of the leg ulcer element, but assessment is absolutely paramount in defining your treatment objectives. So it's looking at your psychosocial factors, your patient factors, and then looking at your actual wound, but not just the wound bed. You also got to incorporate the wound bed, wound edge, and peri-wound skin. Then our step 2 is that wound preparation. Really, really important to prepare our wounds as effectively as possible, remove those barriers to healing and create that optimum healing environment. And within Coloplast, we have mechanical debridement of the All Prep pad. Some of you may have seen it out in clinical practice and used it. It's a very easy to use mechanical debridement pad that breaks down that biofilm and removes that dead devitalized tissue. And then your step 3 is a portfolio of dressings to manage the wound of any depth and stage of healing. And within Coloplast, we have products with 3D fit technology, which means that the foam dressing conforms down to 2 centimeters. So it omits the need to use a filler. So here's just a simplified product choice for venous leg ulcer. So the product guys, so your step 1 is assessing the wound using the venous leg ulcer pathway. And these resources and product information are available on Coloplast Academy. So you can Google Coloplast Academy Coloplast Professionals, sorry. You can tell it's getting into the evening. My brain's going funny. Coloplast Professionals. So yeah, if you look up Coloplast Professionals, you can find more information about the products and services that Coloplast that we can support with. So you've got your step 1, which is your assessment, and then your step 2, like I say, is All Prep pad. It's a form of mechanical debridement. It has 2 sides, but you can use either side. It's a grey in colour, and you can use it to support really preparing those wounds as effectively as possible. And it's really, really important that we do prepare wounds as effectively to ensure that we're removing that dead devitalized tissue. And then your step 3 is your treatment. So if you've got a patient that's in compression hosiery and leg wraps and there's no infection present, you could use the Biotane Silicone or Biotane Silicone Light range. And like I say, these have that 3D fit technology. So if the wound is 2 centimeters or less, you just need the one dressing. You don't need to use a filler. If they're in hosiery and leg wraps and there is infection present, then we have Biotane Silicone AG. If patients are experiencing pain, we also have Biotane iBu. And if there are high levels of exudate, this is a newer product to our range, but it's the Biotane Super Absorber. And this also has a contact layer within it. So you don't need to put a contact layer as well, because it's all within that one dressing. If your patient is in compression bandaging, we've got the Biotane Silicone Non-Border or Biotane Non-Adhesive. If infection's present, we've got Biotane AG non-adhesive, again, Biotane iBu and Biotane Super Absorber. So if you want any more details about the products and services at Coloplast, please go on to Coloplast Professionals. And some of you may be using these products currently in your clinical setting, or if you want more information, just reach out to your team. And this is just an example in clinical practice of where those 3 steps, assess, prepare, treat, have been used on a patient. So this is a patient, he's a 67-year-old male with a venous leg ulcer, has type 2 diabetes. He's got an 18-month history of leg ulcer with multiple infections and antibiotics. And you can see that first photo when he came and presented at the clinic. So he was assessed. His wound was prepared using the All Prep pad, and then treated with biotin silicon AG initially, and then followed by biotin silicon. So that active agent wasn't needed. So then it went to the biotin silicon range. And you can see in the images the improvement that's made in 2 months. So this was a leg ulcer that was present for 18 months, and it actually healed in 2 months using assess, prepare, treat. So now we're going to move on to the next element of today's session, which is the Meet the Coroner in Court. So we're going to deliver some videos. Whenever I say videos, I feel so old. It's like I need to get with the time. So we're going to watch some 4 videos, and you're going to, at the end of it, make your conclusion on what you think the conclusion should be for this coroner's court. And in between each video, we're going to do a little poll. So like I say, for some people, the polls don't work, or they don't have the technology that they're able to press the poll. If that's the case, just type in the chat if you can. And in between each of the videos, me and Charlie will just see what's coming up in the chat and have a bit of a discussion. So without further ado, I'm going to move on to the first part. If you can just let me know if there's any issues with sound or anything, Charlie, because there is quite a lot of people on the call, and it's playing. You may find that the mouth doesn't go in time with the sound, but as long as you can hear it, that's absolutely fine.
I'm resuming the inquest this morning into the death of Elizabeth Mary Black, which was initially opened on the 27th of June 2021. It's my duty today to listen to the evidence requested in order to assist me in answering 4 questions: who the deceased was, and when, where, and how they came by their death. Who, when, and where are... It's how they came by their death I need help with. I confirm the deceased's full name was Elizabeth Mary Black. She was born on the 1st of January 1942 and died on the 14th of June 2021 whilst an inpatient at Spiral Down Hospital. In order for me to be able to issue a death certificate, I need to establish the circumstances surrounding Elizabeth's death. I will gather the evidence, and based upon that, I will then issue a death certificate. Depending on the evidence heard today, it may be that I cannot conclude death due to natural causes, in which case I will form a narrative version. Under Rule 42, no verdict shall be framed in such a way as to appear to determine any question of civil liability or criminal liability. That is for the courts to decide. Based on the witness statements I've received to date, I have decided not to have a jury for this case. I may have to reverse that decision should evidence come to light today that suggests a jury may be required. To assist me today, I have called upon witnesses. Elizabeth was 79 years old. She had a medical history which included hypertension, atrial fibrillation, type 2 diabetes mellitus, rheumatoid arthritis, and varicose veins. We've heard from the pathologist, who established the cause of death to be 1A, sepsis, 1B, cardiac failure, 2A, type 2 diabetes mellitus. The sequence of events started with a skin tear to Elizabeth's leg, which became infected, and sepsis then developed, requiring the limb to be amputated. Following this, further infection set in the surgical wound site, and Elizabeth never recovered from the surgery. We will hear from witnesses today to answer questions relating to the care and management of the wound, in order to determine whether the wound sepsis leading to cardiac failure could have been prevented. Can I please call Ms. Brown to the stand? Can you please confirm your name and current employment?
My name is Ms. Brown, and I'm the clinical manager at Boot Hill Nursing Home.
Were you involved in the care of Elizabeth, and in what capacity?
Yes, I was, as a community nurse at that time.
Can you explain to the court your experience and role?
I am a registered nurse, and I had been working in the community for about 6 months, caring for Elizabeth. Prior to that, I had worked on the care of the elderly ward since qualifying last year.
What kind of things do you deal with as a community nurse?
We see patients who need injections, end-of-life care, pressure ulcer prevention and management, and lots of wound dressings.
Can you describe your involvement in the care of Elizabeth?
Elizabeth was referred to us by her GP to dress a wound to her left leg. She had caught her leg on a chair, which had caused a small skin tear. I saw Elizabeth the day after her doctor had visited and was concerned about a lot of leg swelling. The wound was quite small and I thought it would heal quite quickly, so I just applied a traditional adhesive dressing to her leg. That was on the Monday. I explained to her that everything should be all right for a few days and I would see her again on the Friday, as we were really busy that week.
What were your concerns about the swelling of her legs and what did you do?
Well, I wasn't too concerned. I mean, her legs were swollen, but a lot of our patients have swollen legs. And Elizabeth had just been seen by her GP, but I did leave a message asking the GP to review her.
I understand Elizabeth was visited again earlier than planned. Can you explain what you found?
Well, I visited on the Thursday, as Elizabeth's son had rung our office and requested an urgent visit. And I was really shocked when I saw Elizabeth. Both her legs were now swollen and leaking, and her son had wrapped some towels around them. And when I took the adhesive dressing off, her skin came away with it, as her skin was so delicate. The wound was now much bigger, and her other leg was also leaking.
What did you do?
I called the team leader, as I wasn't sure what I could do. And she told me to use a soft silicone foam dressing and to bandage her legs from toe to knee in a wool bandage and a crepe bandage until she could arrange an assessment.
What happened next?
Well, I was sent in to change Elizabeth's dressings regularly over the next few weeks, and I just continued with the silicone foam and the wool and the crepe bandage. I think for about 2 months or more, there wasn't much change. But some days they were quite smelly with more leakage, and some days they just looked worse than others. We kept taking wound swabs, and she had been on a lot of antibiotics, but she often didn't take them as they gave her diarrhea. I don't think she was going to bed, and I don't really think she did what she was told.
What did you do to encourage Elizabeth to go to bed?
I couldn't really do anything, as I can't make her. But she said she could get comfortable enough in her armchair with her feet on a little stool, although sometimes this made her heels feel sore. Eventually, the team leader was able to visit, and she did a Doppler and put some compression bandages on Elizabeth. At first, I couldn't do this as I needed training. So there was a course which I attended, so I could carry on seeing Elizabeth to bandage her legs. I thought I'd developed a good relationship with Elizabeth, so I was pleased I could continue to see her.
How did you feel her wounds were progressing?
Well, the wounds were getting a lot better, but Elizabeth was non-concordant, and she kept trying to take the bandages off so she could get her shoes on, or pushing them down. On one occasion, a previous nurse had bandaged from further back on Elizabeth's foot, so there was no bandages around the forefoot. I did the same, but by then her foot was so swollen she couldn't get her shoes on anyway. And as the wound was nearly healed, I decided to leave the bandages off altogether. I thought this would give the wound a chance to dry up and to heal properly. And I just continued with the foam dressing as Elizabeth was really unhappy.
Did Elizabeth's legs deteriorate?
Yes, they did, and ever so quickly. I panicked and I called the tissue viability nurse myself. The TVN came out and checked Elizabeth's Dopplers again and agreed that she needed compression bandages. And she talked to Elizabeth for a long time about how to rest her legs properly and the importance of proper bed rest, but also plenty of exercise and good nutrition. And she started her in strong compression. I couldn't believe how quickly Elizabeth's legs started to improve again. Unfortunately, though, she developed another infection. And this time she was admitted to hospital. And when she came home, her legs were open and leaking everywhere. The skin on her legs was raw. I don't know why they stopped using the bandages, so I just continued with the foam dressing, the woolen crepe. She also now had a pressure ulcer on her left heel, which she said she was admitted with, but I'm sure she never had any pressure ulcers when she went in. In the end, she was admitted again as she quickly developed another infection, but this time when she came home, she had her compression bandages on and she was on insulin.
Did her wounds start to heal again?
Well, at first they did, but then after about 2 weeks, I thought I could see a small bit of bone or tendon showing in the wound, but I wasn't sure. The wound was smelly again, and so I took another wound swab, even though one had been taken the week before. And I said that I would visit again in 2 days. The next day I spoke to the team leader, who requested another visit from the tissue viability nurse.
Why did you not document that you could see bone or tendon in the wound in your records?
I wasn't sure what it was I could see. But when I went back, it was obviously tendon with about 10 centimetres showing. So I rang the doctor, and the receptionist said she was unable to visit and she would ring me back. And when she rang back, she told me the doctor had prescribed antibiotics. But I was so worried, I went to see Dr. Porter myself. And when she eventually agreed to meet me and she saw the leg, she admitted Elizabeth straight away, as she suspected sepsis.
Thank you. I have no further questions.
Okay. Oh, no.
I'm resuming.
Oh, what am I doing? Right. So hopefully Charley will be launching a poll, and it will come up in...
It's all launched.
Oh, it's all done. Get you,
Yep.
Charley. You're speedier than me. So the question is, was Elizabeth concordant? There's obviously a lot of information to take on from that first video. Lots of issues with the care she had. But just for this specific poll, if you can answer, was Elizabeth concordant, yes or no? I'll just give you a couple of minutes. Well, I won't give you minutes. Don't think you need that long. Charley, if you can just...
Yeah, we've got about 50 responses so far. I know there's 204 of you on this call.
Oh,
so come on, we need a few more. If you're struggling to complete the poll question, then just pop it in the chat. That's absolutely fine. At the moment, complete opposite to our coroner's court earlier today, Sam. 81% are saying no, 18% saying yes, and then I've got a few people saying no in the chat. Louise is asking if a mental capacity has been done, patient choice. So I think that's quite a resounding no.
So I've got to get this right in my head. It's a resounding no, she wasn't concordant. Is that right?
Was
that right,
Elizabeth
Charley?
concordant? No, she wasn't concordant.
See, I've got it now. Sorry. It's an evening. My brain doesn't work as effectively. So the thing is, when she saw the tissue viability nurse who spent time, spoke to her, explained the reason, she did have the compression on, didn't she? So at that point, she was concordant. Also, I think it's worth noting, they were saying that she wasn't concordant because she kept pushing down the bandages or wanted to take them off because she wanted to get her shoes on. So what could have been done differently there? When we think about all the solutions we have available to us, why were we still carrying on? The wound was healing. She was in compression bandages. Could we have maybe utilised compression hosiery to ensure that that would support her getting her shoes on? So was that her being non-concordant, or was that us maybe not exploring other solutions to make it more achievable for Elizabeth to continue with her compression therapy? Anything else coming up in the chat?
Yes, Sorry, Sam. Lots of people saying that that perhaps initially she wasn't concordant, but it seems after the TVN visited she was. Was there not the education and the communication as to why she needed to have that therapy in place beforehand until that tissue viability took the time to explain that? They're
Absolutely, and
also
that's where
talking.
Sorry.
Talking about referral to orthotics as well for suitable footwear. Could there have been something done with that? Could she have been referred to podiatry? Could she have been in stockings rather than bandaging? We need to understand why she removed the bandages and look at what other options are available. Could we be using wraps? Yeah, lots of people putting lots of different comments. I'm trying to keep up with them all.
Amazing, and thank you everyone for getting involved, because it does make the session a lot more fun when we got lots of comments and thoughts going on in the chat. But absolutely agree, we need to make sure that we're thinking of other solutions. So it's having that clinical curiosity. Why was she not concordant at the beginning? Why did she not want to get into bed? She was sleeping in a chair. Could we have explored that more? Could we look to other solutions to have supported her at that point, to ensure that she was being able to elevate her legs? She was elevating them on the stool and getting sore heel. Well, what's that an indication of? Obviously, pressure damage is then therefore happening. So what other solutions can we do? I think sometimes we need to explore that much more. So great conversation, great chat. Anything else, Charlie, before I move on?
Yeah, Nikki's just put a really good comment in here. Need to understand the barriers to the treatment. Was it not explained, or did her progress result in her thinking that she didn't need to continue with that compression? That's a really good comment. People talking about safeguarding, Datex, maybe equipment. Did she need to have a hospital bed downstairs so that she could go to bed if her bed was upstairs? Was she struggling with those stairs? Capacity keeps coming up, pain management, physio review, and then somebody mentioning they wondered what the documentation would look like regarding her compliance.
Absolutely, great spot, and very good clinical curiosity, because you're already thinking, you're exploring those other options. So great comments. Brilliant. I'm gonna move along unless there's anything else, Charlie. I'm sure I know what it's like when you're trying to man the chat and things are pinging in and it's all going off. So I'll move on, but if there's anything else that comes through, we can always discuss it after the next video.
Brilliant. Thanks, Sam.
Okay.
I now invite Mrs. Smith, representing Community Services, if she has any questions.
Thank you. Yes, I do. Am I correct in thinking that the community nursing team you were working in was under a lot of pressure at this time due to sickness and the taking over of another patch?
Yes, it was terrible. I was missing my lunch breaks and working late every day. There's only so much you can do with 20 or more visits a day.
Did you keep measurements of the wound and report them to your team leader?
Yes, as much as possible, but I knew how busy the team leader was, and she didn't always have the time to listen to me.
Would you say that you had developed a good relationship with Elizabeth?
Oh yes, but she could be quite naughty and non-concordant at times. But we mainly had a laugh about it.
No further questions, Your Honour.
Ms. Best, representing Dr. Porter, the general practitioner, do you have any questions?
Yes, thank you. I notice you took several wound swabs. Did you ever discuss these with the doctor?
Not directly, but I rang and spoke to the receptionist.
Why is it that I cannot see any evidence of this? Did you record it anywhere?
No, I expected the receptionist would record this information in her records.
Did you not consider it important to record your conversation?
Well, not really, as the doctor wouldn't see it in our records, would she?
No further questions for this witness, sir.
Thank you, Ms. Brown. You can stand down. I'd like to call to the stand our second witness, Dr. Porter. Can you please confirm your name and current employment?
My name is Dr. Porter and I'm the lead GP at the Sunnyside Surgery.
Were you Elizabeth's named GP?
Yes.
How many times did you see Elizabeth between November 2020 and June 2021?
Twice. Once when she first injured her leg, and then again in June when the community nurse alerted me to the deterioration and I had Elizabeth admitted to hospital. She was also seen earlier in the year by the practice nurse for disease monitoring.
Would you say it was normal for a GP not to visit more frequently for someone with a wound of this nature?
Yes, I would say that's normal. I would expect the nurse to take the lead in wound management.
Would you have been aware of the risks and the deterioration of the wound?
As I said, I would expect the nurse to keep me updated if there are any problems.
Clearly, the nurses tried to contact you.
Please don't interrupt the court. You'll get your chance to ask questions later. How did you manage the results of the wound swab?
I would have only acted on the results if the nurse had contacted me.
Did you know that the nurse contacted you after the swab was taken at the beginning of June when she was concerned that the wound was swelling?
I can't answer that question. I have no details of that conversation, so I have no evidence that it ever took place.
How did you communicate your concerns to the hospital staff when you arranged admission for Elizabeth?
I had a telephone discussion with the on-call vascular team.
And was it your impression that Elizabeth would be admitted straight to the vascular ward?
I presumed, possibly. Well, I suppose I couldn't be sure, as I don't know how this would be dealt with in acute.
Thank you. I have no further questions. Ms. Best, any questions?
I don't have any questions.
Mrs. Smith, do you have any questions?
Yes, I do. Dr. Porter, why did you not visit when the nurse first rang you?
Well, I would have been in surgery at the time. I said I would prescribe antibiotics, and I did speak with the nurse as she was very insistent. And I did actually visit at the end of my surgery.
Is it common that there is a failure to record telephone conversations?
I can only presume that the receptionist was too busy to record all calls, but she was adamant that no one called about Elizabeth.
Do you think that you might start getting the reception staff to record all telephone conversations?
I object to this line of questioning, sir.
I agree. Please move on, Mrs. Smith.
What did you think when you saw the wound?
I was very concerned and I arranged for urgent hospital admission.
Why did you not write a letter to go with the patient?
I had discussed Elizabeth on the telephone with the on-call vascular team. I didn't think a letter was necessary. I had very little time and I expected the wound to be looked at straight away.
I have no further questions for this witness.
Thank you, Dr. Porter. You can stand down.
Right, okay, so Charlie, the whiz, will be putting on another poll, and then you can answer it. I think Charlie said there's 250 of you on here, so let's try and hit 100 responses this time. I don't know how many we got to last time. And do use the chat function. So the next poll should be up, and it is: when is a wound swab indicated? If the wound is not progressing, if the wound is locally infected, or unsure. And if you start answering that, if it's up.
Yep, it's up. We've got 55 responses so far.
Let's try and get to 100. And I think you will see throughout this that a lot of the failings and a lot of the issues that happen with Elizabeth, just think about that communication and where communication is broken down, and it will just sort of, you can see the journey and where things have been missed or miscommunicated for Elizabeth. So I think that's enough time. How many have we got to now, Charlie?
We've got 101 responses on the poll and quite a few in the chat. So 32% if the wound is not progressing, 65% if the wound is locally infected, and 1% are unsure. And in the chat, we've got lots of people saying both. If the wound is not progressing, if a wound is deteriorating, I would also send a swab when the wound is infected and if it is unclear. If signs of systemic infection are present, both when there are signs of infection, wound exudate, erythema, as well as non-healing. If suspected infection, both. I'd want to say when there are clinical signs and symptoms of infection to the last poll. Both, bit of both, especially if appropriate treatment is being applied. When a wound shows signs of infection, if the wound's not progressing or it's deteriorating, both. So lots of people saying both, lots of people saying if the wound's locally infected.
Okay, so firstly, you absolutely follow your local policies and procedures that are in place, because I know that there is variation across clinical settings, so you would absolutely just follow your own policies and procedure. So if the wound is not progressing, so think of your chronic wounds, it's not progressing, it's not saying deteriorating, it's just not progressing. So for me, I'm thinking potentially there's a biofilm there. So if we've got a biofilm within a chronic wound and we're swabbing it, what will we actually be swabbing? We'll be just swabbing that biofilm that's sitting on the top. So the results aren't really going to change that treatment, are they? So we need to think about how we can break down that biofilm and start that wound on a healing trajectory. If the wound is locally infected, if per your policy it is absolutely necessary to do a wound swab, then do that. Make sure you prepare that wound as effectively as possible before you take that swab. But not only do the swab, it's really, really important that you start changing your treatment plan. So adding in your active agents, whatever's available on your dressing formulary, to ensure that you're actually treating that local infection, not waiting for swab results. Really, really important. So hopefully that's supported that a bit more. Any more in the chat, Charlie?
Yeah, Bethany Choate, I hope your training's going well, because she's doing her nurse training, has said wound preparation is key. Absolutely, we need to reduce the bioburden that's sat in that wound, remove the devitalized tissue and any debris. So absolutely, that is key. People suggesting some of the different policies that they've got in their area. So Catherine saying they have a red, amber, green with wound swabbing. Some people saying that the GP protocol, if only if signs of infection or deterioration, not stagnation. So it's very much dependent on where you work locally, because Sam and I both cover lots of different trusts and everywhere will do this slightly differently. Some trusts I work with don't swab wounds at all anymore. Some will swab every wound that comes on the caseload, and then there's lots of different variation to that in between. So whatever your local policy is what you have to follow. Jennifer is just saying she wouldn't take a swab just for a wound not healing. I'd look at treatment and see if any other things could be optimized: dressings, compression, diabetes, nutrition, smoking. Also people talking about taking observations and making sure that you check for the results, because sometimes the GP misses them. It can vary between practices. They cover, this lady Laura covers 4 and they all do it very differently. What's this one here? Sorry. My arm hairs stood up when I heard nothing was documented with the GP communication. Would be best practice for the nurse to have documented the wound swab, when it was obtained, sent, and also all communications with the GP surgery, time, date, who she spoke to, and their role in the conversation. Would also be best practice for the GP to document the encounters with other professionals. My local GPs are very good with this. Absolutely, and I completely agree with you there. Phone calls are often the one that get missed in documentation. They might say who they've spoken to, but they don't necessarily put in the context of the conversation. So absolutely, that should have been documented by both parties.
Also, just another thought, whose responsibility is it to follow up on that swab? Is it the GP's? Is it the nurse that took the swab? I know that when we did this session earlier this morning, so some systems you can get into, some other systems you can't get into to look at results. But in the video, you'll notice that she said that a swab was taken a week earlier, but then she still took another swab, and you would assume that's because maybe they either the swab results weren't highlighted or nobody followed up on that swab to look at results. So just throwing that out there as another thought process, because I know that there was quite a bit of chat earlier around that.
There's just Dot here. She's put an amazing saying, and I love that. We do no swabs without OBS and create a care plan to check the wound swab on system 1. I love that. No swab without OBS. I love it. Leslie,
Brilliant.
if I prescribed antibiotics as there was localized signs of infection, I would still obtain a swab to ensure I prescribed the correct antibiotics for the strain. Whoever takes a swab should follow up the results. I think it's both people's responsibility. May have to chase the GP, what we would discuss around who looks at those. It's the responsibility of whoever has taken that swab to follow it up. Bloods could be taken for inflammatory results. Yeah, so lots of really good comments coming through. Thank you, everybody.
Great, brilliant. I'm going to move on, but again, if there's anything that comes through while the video next one's playing, we can always follow that up after the next section. Here we go, part 3.
I'd like now to call Ms. White to the stand. Please confirm your name and current employment.
Yes, I am Miss White, and I am the Advanced Nurse Practitioner in the Accident and Emergency Department.
How long was Elizabeth in your department?
She was prioritised as per our targets of admission within 4 hours.
And what treatment did Elizabeth receive?
She had been started on intravenous antibiotics, as I was sure she had an infection.
Where was the infection?
It was unclear initially, but we now know it was in her leg.
Am I correct in understanding that the bandages were not removed from Elizabeth's leg whilst she was in the Accident and Emergency Department?
Yes, that's correct.
Is that usual practice?
We have very few bandages in the department. We see lots of patients coming in with bandages on their legs and often compression, and we don't have any compression bandages. If we did, the nursing teams are not trained to apply them.
Would you always remove bandages now?
Oh yes, straight away. We have a good supply of dressings and bandages now, and pathways in place for any patients who come in with leg ulcers.
How did Elizabeth seem to you?
Not very well. She had tachycardia and raised blood pressure. Bloods were requested, and inflammatory markers were very high, as were her blood sugars. She was showing signs of infection.
So why did you not remove the bandage on her leg to check the wound for infection?
Well, I actually suspected a chest infection, and I did start her on intravenous antibiotics. I did not realise she had an ulcer. No one had told me, and it was a very busy day in the department.
Was the vascular consultant called to see Elizabeth?
No, I arranged for Elizabeth to be admitted to the medical ward.
Were you aware that Elizabeth's GP had spoken to the on-call vascular registrar?
No, I was not made aware of that call.
Thank you. I have no further questions. Mrs. Smith, any questions for this witness?
No, sir. I do not have any questions for this witness.
Ms. Best, do you have any questions for this witness?
Yes, if I may. What I cannot understand is how this lady came through the Accident and Emergency Department without anyone looking at her wound. Could you shed any light on this?
We are not wound care experts and have little experience of treating ulcers in A&E, but we have since had some training on wounds and leg ulcers from our tissue viability team.
Perhaps you may make more of an effort next time.
Please think carefully about your line of questioning. This is not helpful to the court. Do you have any further questions?
I apologise. I have no further questions for this witness.
Thank you. Thank you, Miss White. You can stand down.
Right, okay. So I'm sure Charlie's already done it.
Yes, I
because
have.
she's a speed demon. So obviously you're going to have your next poll that's up, so please answer it. I'm going to aim for, let's go for 110, get more than 110 this time, because we got 101 last time. So the question is removing compression and stopping this therapy harm? Yes or no? So I'll just give a little bit of time for you to answer it or write in the chat.
So we've got 50 responses so far.
Okay, good. Any more?
We've got 79.
Oh, okay, getting there.
Oh, we're in the 80s now. And quite a few things coming through on the chat.
Yeah, there is so much, isn't there, that
yeah,
you know, we do the poll questions because otherwise you know, we could be here for 3-4 hours discussing all the points that come out of this. So hopefully we're
right,
around 100.
We've got to 92. So
okay, we'll go for
69% are saying yes, 30% are saying no, and then we've got not if it's due to an assessment, compression should have been removed to assess. So I think what we mean with this question is it's absolutely right that they need to remove the compression to assess the wound. But what we're saying here is removing that compression and stopping that therapy altogether. Is that harm? So absolutely right to take it down to do the assessment. Somebody saying there's not a straightforward answer here. It depends on the assessment. The thing that we have to have in the back of our mind is the best practice for recommendation for the management of venous leg ulcers is compression, unless it is clinically not indicated. Okay, so you have to think about that in the back of your mind. You wouldn't stop medication if there was no clinical indication, so why would you stop compression? Excellent point there. Surely not if it's for medical assessment and review to determine the treatment, not if it's required for the full assessment. Both, more context is needed for that question. So what the A&E nurse was saying there is they don't have bandages in the department. Nobody can do compression. So ultimately they didn't remove the bandages, but had they removed them to do the assessment, there was nobody that would be able to put that therapy back in situ. Okay, and unfortunately, that happens quite a lot in the acute. It is something that is being worked on, but quite often there aren't the people like there are in the community that have had the training to be able to apply compression therapy. Now, with regards to your documentation here, if you work in the acute and there is nobody available to do compression and you don't have compression garments in situ in your trust, you would need to document that the compression had been removed for assessment. There was nobody that was able to reapply the compression, therefore that therapy is halted at present. You need to cover that. That is how you would cover it in your documentation. However, if there are people that are available or you have other things available, so some trusts may use a reduced compression hosiery kit, for example, then the expectation is so long as that patient doesn't have any red flags and you're able to put them back in that compression, that's what you should be doing, because stopping that treatment when it is indicated and not reapplying it is classed as harm. Okay. Oh, I got on my high horse a bit there, didn't I? Sorry.
I'll just let you go for it, Charlie.
Sorry,
so
Sam.
Absolutely. Compression is a treatment. It is a therapy. It is something that is needed. So to just remove it without continuing that therapy, you've got to document why. And it may be that you don't have clinicians with the right skills to be able to do that. And you have to document for how long a period you are anticipating that therapy is going to be removed. And you try and omit it from happening. So it may be that you might have to reach out to other specialists in the area. I know that when I worked, I was in an integrated trust, so I covered acute and community services. And when someone from community ended up going into hospital with compression, we often got the community nurses to come in and support. I do understand that actually our community hospital was next to the district nursing team, so they were able to support that. But again, it's thinking how we can ensure that therapy can be continued as appropriately as possible. But also, on the same token, this lady had presented into A&E, and to be able to do a full assessment, they should have done a full body check. So that will have included removing those bandages, putting her into a temporary dressing, but to be able to do your skin checks, to be able to fill out your risk assessment forms, that should have been removed. And I think, like Charley said, there is a lot of work happening around this. And I think that trusts and areas and clinicians that I talk to, they're aware of that inequality and are trying to change this this practice, because it's just not effective. We are potentially causing further harm and distress to patients by removing a therapy that they need. So really good discussion there. Anything else coming up in the chat, Charley?
Yeah, I think people weren't quite understanding the question initially, because there's lots of comments saying that it's got to be removed to do the assessment. Absolutely, we're not saying that it shouldn't be. We would always advocate that you remove any dressing if they're admitted into the community or into the acute to find out what's going on under that dressing, under those bandages. You need to do the assessment. People are more understanding now, it's being explained. There are comments around the fact that the acute don't often compress, and even tissue viability nurses in the hospital don't compress. I do have to defend them a little bit here, because I was one of those TVNs in the acute. They're often much smaller teams of tissue viability nurses in the acute, and if they did the compression therapy for every patient that was admitted with compression, that is all they would do all day, every day. So unfortunately, there are lots of other wounds and pressure ulcers to consider. So some trusts will take the decision that if there is nobody else that can compress those legs, the compression is removed. The upside generally to the patient being in hospital is that they are in bed a lot of the time, so their legs are elevated, which often helps with that edema and reducing that exudate. So although they're not in their compression, they have got that elevation. It's not ideal, and I don't defend it at all. There is a lot of work going in behind the scenes in lots of trusts to try and upskill people and make sure that there is something, even if it is reduced compression, that can go in so that we can continue that therapy. People saying that their relatives have asked them to go, patients' relatives have asked them to go in because they've been in hospital for weeks on end and nobody's actually looking after those wounds. Hospital need to tell the community why they've been sent home without the compression. Clearer communication. There might be a reason, but we have to guess and then re-Doppler. Absolutely, and a lot of this always comes down to communication and the lack of between the different services. So absolutely agree with all the comments that you're making, and please keep them coming. And thank you for getting involved.
Amazing, thank you. I'm going to move on to the next video, and it should be playing now.
Can I call Nurse Spears to the stand? Can you confirm your name and current employment?
I'm Miss Spears. I'm a registered nurse, but I've moved from the medical assessment unit and I'm now on the rehab ward.
Were you involved in looking after Elizabeth?
Yes, I was.
Am I correct in thinking that the bandages were left on her leg for a further 4 whole days before being removed?
Yes, that was normal practice when patients had been admitted from community. We usually find out when the bandages were due to be changed and change them on that day.
How did you know when Elizabeth's bandages had been changed?
Elizabeth told me. She was quite good at communicating. She did ask for them to be changed, but I said no because it was important we didn't disturb them.
How was Elizabeth being treated?
She was needing a lot of help to do things, and we were trying to encourage her to eat. And she was having intravenous antibiotics, and her MUST score was improving a little.
What happened when the bandages were removed?
I was horrified. Her leg looked like it was rotting. I'd never seen anything like it. So I called the doctor, who called the vascular consultant, and she was moved to the vascular unit. And I understand she had an amputation the next day. She was very poorly after surgery and had an infection in the stump wound. She was on critical care, and I believe she died 2 weeks after surgery.
Thank you. Mrs. Smith, any questions?
Yes, thank you.
Miss Spears, would you always ring the community nurses to discuss the bandaging?
Not really. I'm not sure we need to. We are the people looking after her in hospital.
You told the court that you would ask the community nurse when the bandages needed changing, but it would appear that on this occasion you did not do so. Why was that?
Well, Elizabeth could tell me when the bandages were changed, which was on the day she was admitted, so I thought they'd be all right for a few days.
What if Elizabeth couldn't communicate with you?
Elizabeth's son also says she had her bandages changed when she came in.
No further questions, sir.
Ms. Best, any questions?
Yes. Miss Spears, if a person is admitted to hospital with a wound, surely as part of their care you should assess the wound.
I suppose you could say that.
Are you agreeing with me then?
Well, yes and no. I can see your point, but hospital policy is to leave bandages in place until discussed with the community nurse managing the care.
Was the management plan discussed with the community nurse?
I'm not 100% sure. I didn't talk to them, so I don't know if anyone contacted them.
There is no evidence that the ward staff contacted the community nurses at all.
Thank you, Mrs. Smith. Can I remind you not to interrupt, and then perhaps this expert witness can answer the question.
Was there any documentation in her records?
I'm not sure. I'd have to consult records.
Well, go ahead then.
No, I cannot find anything about the community nurses.
No further questions, sir?
Thank you. Thank you, Nurse Spears. You can stand down.
Okay, so that was part 4. And I've gone a bit too. Okay, so I think Charlie, you're going to pop the final poll question in relation to the video. So that is, whose responsibility was it to care for the wound whilst the patient was in the acute setting? Acute care nurse, community nurse, GP, or ward doctor?
Around 30 responses so far.
Brilliant. Well done, everyone. I know it's the day's getting on now, isn't it? I can see the sun's starting to go down. Thank you for all your engagement.
75 responses.
75, brilliant. And if you can't use the poll, just write in the chat, which I think is being well used.
So we've got we've got 90 responses, 84% saying the acute care nurse, 14% saying the ward doctor. And in the chat, we have got acute care nurse, hospital staff, doctors and nurses, acute care nurse with input from the community. Someone saying as a nurse, she'd never finish a shift without checking her patient's skin. Excellent. Well done, Shannon. Ward doctor, acute care nurse, TVN nurses within the hospital, acute care nurses. Wounds should have been assessed when she was admitted as part of a full skin assessment. Acute care nurses, acute care nurses. Anything
that
different?
seems to be the biggest response. So absolutely, it is the team in the hospital, because she is under their care. So it is the acute nurses, but also the ward doctor. It's the clinicians that are in the hospital that should be responsible for ensuring that Elizabeth is properly assessed and that wound is given the attention that it clearly needed. So well done, everybody, on supporting and interacting with the poll. Is there anything else coming up in the chat, Charlie?
Acute care nurse again. Pamela, sorry about that. She said the poll keeps jumping when she's trying to select it. I do apologise. Technology is not my bag. We usually have somebody that joins us on these that is a tech genius. So you'll just have to do with me tonight, and I don't know why it's doing that. So I apologise for that. People saying that in A&E, as part of their A to E assessment, this should have been looked at. Acute care nurses should be doing skin inspections and skin assessments. How much?
And I think also just thinking, you know, to be able to do your purpose T or Waterloo assessment, part of that is to do that full skin assessment. The fact that she had those bandages remain in situ for 4 days, in, you know, then that whole documentation is flawed, isn't it? Because if they'd done a risk assessment, they haven't completed that properly, because they haven't done a full skin assessment, and it just has an impact on all that documentation. So bringing it back to documentation, you know, it may, how can you complete your Waterloo, your purpose T risk assessment if you haven't visualized the skin? So just wanted to add that in.
Someone saying quite rightly, especially because of the reason for admission and the source of sepsis. So what could have helped that is the letter from the GP if that had gone with the patient.
Communication all the way through this, isn't there? It's just like a thread of communication breakdown throughout each of the sections of this. So really, really good point.
People just sharing some of their what their policies are. Major lack in communication and lack of continuity of care. Absolutely.
Brilliant. Well done, everybody. So now it's another poll. And it's what's the conclusion? So I shall pop up the conclusion. Is it conclusion? Is that the word I'm after?
Yes, it is.
Yes, thank you. So is it natural causes, accidental death or a misadventure, unlawful killing, suicide, neglect or narrative? So hopefully the poll is up, and I'm sure it is. Perfect. So yeah, so you are now the coroner, and you have to come up with what you feel would be your conclusion after hearing the evidence.
So we're on about 40 responses at the moment. Some things coming through the chat as well.
Brilliant.
And 70 responses. Come on, I'm trying to wait till we get to 100. Let's see if we can do it. Sam and I get quite competitive over this, and we like to meet the number that we get in our heads. 99, come on, yay! 102, excellent. So we have got 74% saying neglect, 2% saying natural causes, 2% saying accidental death, and 20% saying a narrative. And then in the chat we've got neglect, neglect, narrative, neglect, 100% neglect. Some say neglect or narrative. Let's just see if there's anything else. Oh, Michelle's saying there needs to be a regulation 28. That's the next question, Michelle.
Jumped ahead.
And then, yeah, I think the overwhelming response is neglect.
We often when we do this, that is often the resounding thoughts and conclusion that people come to, but we just have to relook at what neglect is. So neglect is a gross failure to provide the deceased with basic needs. And again, when we think about our basic needs, shelter, food, water. So, when we're thinking about this situation, this scenario that we've gone through today, it would not sit in that neglect. But I know that everyone is very passionate. You can see where failings have happened for Elizabeth. So the actual conclusion of this is a narrative. So the coroner sets out the circumstances of the death in a detailed way based on the evidence heard. And I think that it's very emotive, isn't it, when you listen to all these scenarios and sections of it, because you can see where she's been failed. But in terms of a conclusion, neglect is down to that gross failure of basic needs. So hopefully that's explained that part for you. Anything else coming up in the chat, Charlie?
No, just Laura, she was torn because it didn't sound like she was provided with some of the basic needs. That's it at the moment.
Brilliant. Okay, so Michelle, who's already set off answering the next question. I'm just going to check with Charlie. Do I need to move the slides on, or are you just going to pop the poll up?
If you move the slide on, then everyone can just have a quick read before I launch it, because when it launches, it's right in the middle of the slide. So I'll let you all have a quick read.
This is about that regulation 28. So if the coroner's heard that evidence and feels that there may be further avoidable deaths, they will request this regulation 28, and they send it to the clinical setting, and they have 56 days to show how they have made those changes according to the coroner's recommendation. So earlier we went through an example that I got off the internet around a regulation 28. So I think is it a poll of yes or no, or is it who should have or could have?
It's a yes, no, or unsure, just around a regulation 28. If you think there's a specific area that needs to have it, or all three areas, please pop that in the chat. You're more than welcome to do that. Right, we need to try and get to 110 responses this time, because we did 100.
Yes, come on.
So come on.
It's the last poll, isn't it? This is the last one.
It is the last one.
Come on, let's go out with a bang.
We're at 88. $97.
Brilliant. Come on.
99.
13. Ooh.
We're at 100.
Excellent.
104. Oh, sorry, Emily. Emily says it's not letting her submit her answer. Sorry about that.
We'll put Emily, so it's 105.
We're at 106, 107. Come on, 3 more of you. Then you'll have made our night.
Then you won't be able to go and get your cup of tea soon.
109. Come on, one more. 110. Yay!
So what's the results from it,
It's
Charlie?
a 95% resounding yes.
Okay.
There was 3% that said they were unsure, and then in the chat, yes, all 3 areas they need training. All three areas need improvements. All areas need to improve. A&E, all 3 areas can show lessons learnt. Yeah, all areas need to improve communication. 100% agree with you there, Sharon. Communication, transfer documents, training, absolutely, Catherine. Community mainly as the primary or initial contact, Pamela said. Oh, sorry, Holly. She said she didn't realise until now she had to click submit for the poll.
Well, next time you join us, you'll be the speediest. You'll be on it. That's brilliant.
So Jane, sorry, Sam, Jane's just made a comment. I'm not sure this would ever happen, but we also need a wound passport. And I know I and lots of other TVNs have been saying that for a long time. We have catheter passports. Why don't we have a wound passport? But you know what would happen? They'd all just get lost, wouldn't they? Or they'd just. But I agree, they definitely do.
We did do a trial of a wound passport when I was clinical. We sort of highlighted it, and we had what compression they were in, the wound type, ABPI results, and we used to update it. But unfortunately, they did go missing. But I think we are getting more digital. So, you know, potentially in the future, we could have an app where the patient, you know, most patients do have smartphones now, and you could have an app that has all that detail on, because generally you're not going to lose your phone. So I think it is coming. I think there is a lot more digital solutions that will be coming. Like I say, some clinicians I've been to, they've used AI, so they literally, it records their whole conversation. So you can literally say wound measures, blah blah blah. Tissue type 80% necrotic, 20%, and then it summarizes it all, and then you've literally got a printout. So I think there are more digital solutions. So, you know, a wound passport could well be on the horizon. With our Healthy IO apps as well, with our wound maps, how can we make those transferable between systems and services? So I think there's a lot of financial money going into trying to expand this and making it more accessible and more easier for us. So there is hope.
Some areas saying they have a passport. So East Sussex do. Catherine is saying that they have pressure area passports. They occasionally use them for wounds. She'll copy it and send a copy. So that'd be great for everybody to have a look at. Thank you. Somewhere's just launched a leg ulcer passport. They had a Leslie saying they had a pressure ulcer and compression passport, but sadly that didn't quite work out. If only we all used the same system, Izzy.
Oh,
I know.
Oh, wouldn't that be amazing?
Wouldn't that make life so much easier? Getting catheter passports are a nightmare. It's a godsend if a patient is transferred with one. Leg Club have passports, but it's the responsibility of the patient. Leg ulcer register in Lancashire, Cumbria. There's a wound care plan within the patient's home that can be taken with the patient. A document is only as good as the people who use it. Isn't that the truth?
Yeah, well done. Good. Good. I think we've gone a bit off where we were. So regulation 28, I'm bringing it back because I know that everybody wants to get a cup of tea and either finish their shift that they're on if you've joined us from work, or get home and put your legs up. So in terms of this as a regulation 28, so throughout those videos, if you can remember, the hospital was showing the changes that they had made. So within A&E, they now have access to bandages. They had training from the tissue viability team. So what they are doing is they're showing what changes they've made to prevent that happening again. So they mitigated it really because they were showing how they've changed their process. They've learned a lesson and they've now put something else in place to stop that happening again. So it wouldn't be a regulation 28. So that's that, I think. Have I covered it all, Charlie?
Yes, I think so.
Thank you. Brilliant. I'm just gonna move along just to finish this session. So again, I cannot thank you all enough for all your interaction. Great conversation in the chat. Really does make this session so much more valuable. Please scan that QR code for our future webinars. I know we've got one coming up on, is it skin tears?
Yes.
Charlie? Yes, thank you. Skin tears. So please scan it and see what our future webinars on. You can go on to Coloplast Professionals. You can see more information about our products and services and our educational support. We also have podcasts, so it's called Wound Care Conversations. And if you want to listen to me and Charlie some more, we go through different aspects, all wound care related, and you can tune into it on all your normal devices, Apple, Spotify, Google, Audible. And if you're a community nurse, for example, and you're driving around and you just want something to listen to, give it a try. It's called Wound Care Conversations. So I think that is it from us today. I'll just double check there's no more slides. I shall stop sharing. There we are.
So lots and lots of thank yous, Sam, for a really informative and brilliant session. It was beautifully presented and everyone has learnt a lot from it. I have popped the link in for the skin tear webinar in the chat. So if the QR code didn't work for you, there is a link in the chat that you can click on. We will be sending you a certificate and a copy of the recording. We won't send the slides, but it will be a recording. Our colleague Ben will be looking to do this tomorrow, but do keep an eye on your emails over the next couple of days and do check your junk folder as well, because sometimes it goes in there and that's where your certificate's going to be. But thank you all for attending, and especially on an evening if this is your in your own time, and we hope that you will join us again at another webinar.
Thank you all.